Hello everyone, welcome to sqadia.com, and in this section of the lecture topic Benign Lesions of the Uterus, we will talk about the examination and management of the fibroids. In this section, we will talk about what are the complications and clinical features of fibroid, what are the different examination procedures and how they are managed. So, complications of the fibroids. The complications of the fibroids, as we mentioned before, also degeneration can take place in the fibroids. And these degenerations can be calcific degeneration, it can be hyaline degeneration, fatty degeneration, red degeneration, which is very common in degenerations which are present in during the or the fibroids which are present in the pregnancy. So red degeneration is common in fibroids which are formed during the pregnancy. In calcific degeneration, calcification takes place in the fibroids, causes hardening of the fibroids also. In fatty degeneration, there is fatty deposits in the fibroids leading to fibroid degeneration. And in hyaline, there is hyalinization of the fibroid tissue take place. Then the other complications of fibroid is necrosis of the fibroids. Necrosis is the death of the fibroid cells or tissues, and usually the main cause of necrosis is due to decreased blood supply of the fibroids, due to torsion of the fibroid, because then the blood flow is stopped or decreased. Then another complication of the fibroids might be infection. Infection of the fibroids occur, or it can be sarcomatous changes. It's rare, not very common, which are the changes leads to the malignant changes like the embryonic tissue present in the embryonic tissue or cells. So sarcomatous changes might occur, but it's not as common as other complications of the fibroids. Then there might be a torsion of subserous pedunculated fibroids. Fibroids which have stalk attached to them, the torsion or twisting of those fibroids is common, and this can lead to decreased supply of blood to the fibroid and cause different complications like necrosis or death of the cells. Then another complication is hemorrhage. Hemorrhage is the blood flow, or it can be intracapsular blood flow, or it can be ruptures vein of subserous fibroid, which can lead to intraperitoneal hemorrhage or bleeding into the peritoneum. And then polycythemia is another complication of fibroids. What's polycythemia? Polycythemia is increased number of red blood cell present, increased production of red blood cell. So polycythemia is due to mainly erythropoietic function by the tumor. Erythropoietin is produced by the tumor that leads to the, in this case, of fibroids. Normally, erythropoietin is produced by the kidneys, and it causes production of the red blood cells. But in this case, tumors start producing erythropoietin, and this can lead to increased production of the red blood cell, which can lead to polycythemia. This can be due to altered function of erythropoietic function by the kidneys due to ureteric pressure, increased pressure on the ureter. Ureters are the tubes that bring the urine from the kidneys to the bladder. So ureter and fallopian tubes are close. close to the uterus. So fibroid, if it overgrow or if it becomes big enough, it can cause pressure on the ureter also. Increased pressure on the ureter now cause increased pressure on the kidneys, and it can affect the erythropoietin produced by the kidneys, and increased that can lead to polycythemia or increased production of red blood cell. So these are all the complications of the fibroid. Degeneration, then we have necrosis, death of the cells, infection, sarcomatous changes, hemorrhages, or bleeding from the fibroids, or it can be, another is polycythemia due to increased production of erythropoietin from the tumor. Now, the patient profile is usually the incidence is highest between 35 to 45 years of the age. Then 75% of the patient are asymptomatic. Early marriage and frequent childbirth make its frequency high even among the multiparous women. So, early marriage, usually it's more common in the nulliparous females, but conditions like early marriage and frequent childbirth can lead to the formation of fibroids even in multiparous women. Then patients are usually nulliparous. Nulliparous are the females who never give birth to a baby or having long period of secondary infertility. Secondary infertility is once they have pregnancy, then there is no pregnancy or no conception after that. So it's secondary infertility, not primary infertility. So it's common in patients who have secondary infertility or nulliparous patient. Symptoms of the patient with fibroids are usually menstrual abnormalities, dysmenorrhea or difficulty in menstruation or infertility. And there is usually a tendency of delayed menopause also. Fibroids leads to very, very heavy bleeding in patients with fibroids. So usually these patients have delayed menopause or delayed stoppage of menstrual cycle because of bleeding fibroids. So these are all the clinical features of the patient with the fibroids. Now we will talk about some pregnancy-related problems of the fibroid. I mentioned before that sometimes fibroids are also present during the pregnancy. Because of increased hormones during pregnancy, there is excessive growth of the cells or multiplication of the cells leads to the formation of fibroid. And depending on the location of the fibroid, it is managed accordingly in the pregnancy. So usually patients who have fibroids during pregnancy, they complain of lower abdominal pain, abdominal swelling because of fibroid. You can feel the fibroids, some on the side or separately, or small fibroids are usually diagnosed during ultrasound performed during the pregnancy. There is abdominal swellings or lumps. There are pressure symptoms because of the fibroids. If they are growing, they put pressure on the bladder, on the uterus, and the patient complains of pressure in the abdomen. There is usually pallor. Pregnancy also lead to, especially in the early trimester, weakness and loss of activity or loss of interest in performing different activities. So it can also lead to pallor because of fibroids. Sometimes those fibroids bleed also. So patient will complain of pallor and bleeding per vaginum, and that pregnancy is safe, nothing is wrong with pregnancy, but usually the bleeding is from the associated fibroids along with the pregnancy. Next, examination, abdominal examination of the fibroid is important. When abdomen is palpated, usually there is a mass is felt on the abdominal palpation. Feel is firm, more hard, may be cystic or cystic degeneration. So usually when the doctor feels or palpate the abdomen, there is a mass which is mostly, in most cases, is hard and firm. But it can be cystic. We already mentioned there might be cystic degeneration or cystic change in the fibroids, and cysts are fluid-filled sac. So in that case, the feeling is soft as compared to solid masses. The margins of the fibroids are well defined except the lower pole, which cannot be reached, usually, which is suggestive of pelvic in origin. So margins are usually well defined of the fibroid. Surface is nodular, it has nodule, it may be uniformly enlarged in a single fibroid. Mobility of the fibroid is restricted from above downward but can be moved from side to side. So palpation for the mass of the any mass present in the abdomen is use the four fingers. Tips are usually the most sensitive. So four fingers palpation. The mass is usually the firm, hard, can be cystic, margins are firm, and it can be nodular. You feel the nodules, different nodules while feeling the fibroid. Movement is from above downward like this. Movement from above downward is restricted, but side to side, that's how you move, side to side. Side to side movement is good. It can be moved good. So on percussion, swelling is dull on percussion. The percussion is when you put the hand on the surface of the abdomen and you percuss. This is the middle finger is used for percussion. This is the sound produced. This is a resonant sound I am producing. But on the solid organ, usually the sound is dull. Dull sound is produced on percussion. Next, pelvic examination. This is the one figure pelvic exam. Index finger is inserted into the pelvic, and then another hand is pushed the uterus and fibroid down, and when it moves down, it can be easily palpated or felt by the finger. So pelvic examination of the fibroid. Investigations performed is to confirm the diagnosis of the fibroid, usually ultrasound and color Doppler, transvaginal TVS, transvaginal sonogram. Ultrasound is performed transvaginally. MRI, laparoscopy, in which the fibroids can easily visualize with the help of the laparoscope. Hysteroscopy, in which the hysteroscope is inserted into the uterus. Then HSG, sonogram. This is HSG, histosalpingography. Histo is for uterus, salpingo is for tubes, histosalpingogram is performed. And then uterine curate or DNC, uterine curating is removed and then it's examined. So these are the tests to confirm the diagnosis of the fibroids. Then preoperative assessment, then differential diagnosis. In the differential diagnosis, we have pregnancy, full bladder, adenomyosis, which is the excessive growth of glands and muscle tissue. Then there might be myohyperplasia, which is hyperplasia or excessive growth of muscle cells, or it can be ovarian tumor. So these are all the differential diagnoses. If fibroid is present, if pregnancy is there, if the bladder is full, it can be felt as a mass, adenomyosis, myohyperplasia, ovarian tumor. So these are the investigations and differential diagnosis of uterine fibroid. Then tubo-ovarian mass. Tubo-ovarian mass is another differential diagnosis. Management is management of uterine fibroid if they are present in the body, if they are symptomatic or asymptomatic. Asymptomatic means no symptoms present. The fibroids present in the body of the uterus, also known as corporeal fibroids. If they are symptomatic, treatment can be medical or surgical. Surgical is myomectomy. Myo is muscle, ectomy is removal, myomectomy, endoscopy, laparoscopic myomectomy, hysteroscopic resection of myoma. It can be due to laparotomy. And then another method is hysterectomy, myolysis, and embolotherapy. So here, if patient is symptomatic, the options are treatment by medicines or treatment by surgery. Surgery is most likely treatment for the fibroids because these are the growths and they have to be removed surgically. So if surgically, myomectomy is removal of myomas or tumors formed by the growth of muscle tissue. Myomectomy. Myomectomy can be performed by endoscopy or by laparotomy. By endoscopy, it can be laparoscopic myomectomy or it can be hysteroscopic resection of myomas. Then another surgical procedure is hysterectomy. If it's big enough, fibroids, if usually the family is complete, patient doesn't want any more children, then hysterectomy is the preferred treatment, in which especially the complete hysterectomy, in which total hysterectomy when the uterus and tubes and ovaries are removed, known as hysterectomy plus salpingo-oophorectomy. So that's the treatment of choice in cases when the family is complete. Embolotherapy is the therapy in which the blood flow is obstructed, and then usually that can cause the death or necrosis or cessation of blood flow to the fibroid. Embolism is formed. Myolysis can be done by electrocautery, laser, or cryotherapy. Cryo is the surgery by the cold. Then asymptomatic patients, usually they have regular supervision, regular follow-up is important after in every 6 months. And depend on if the size is increasing or if the symptoms appear, then we do surgery. If size remain stationary and patient is symptomless, then follow-up is important. So treatment again depend on symptoms. of the patient. If asymptomatic, do the follow-up. If the size is increasing or if the symptoms appear, then we do the surgery. If the size stays the same or if the symptoms doesn't appear, then we do the regular follow-up of the patient. Now, if there is the fibroid present in the cervix, then again, if they are supravaginal, then we do myomectomy, hysterectomy. If they are in the vagina, then we do myomectomy and polypectomy. So again, body, corporeal fibroids, cervical fibroids, depending on if they are above the vagina or it's in the vagina. If they are supravaginal or in the cervix, usually we do the myomectomy, which is removal of myoma. Hysterectomy is removal of the uterus. If it's in the vagina, again we do myomectomy, or polypectomy is removal of the polyps. Myomectomy is the removal of the myomas. So management depends on 3-4 things basically. Location of the fibroid, whether symptoms are present or not, and then if there are symptoms present or then surgery is the preferred treatment. If no symptoms and size is not increasing, follow-up is important. Thank you for watching sqadia.com.